Welcome once again to Profiles. I'm Ed Highland, and today we'll tackle an issue important to all of us, cancer. In particular, breast cancer, which strikes 1 out of every 7 women. Breast cancer in men accounts for less than 1% of all breast cancer cases, but it does happen. Karen Dow is a UCF professor of nursing and a researcher into the quality of life among breast cancer survivors. Thank you so much for joining us and telling us a little about this very important subject, I think, for everyone, because there's so many. We talk about numbers and such, but we're really talking about people. We're talking about families who are affected by this.
Well, thank you for having me.
I wanted to talk a little bit about the research that you've been involved with. I have to refer to my notes here a little bit because it's kind of a long thing, but the Breast Cancer Education Intervention, the BCEI study. Now, it's been an ongoing program for the last almost 4 years now. And final results starting to gel here a little bit. Give us an idea of just an overview, if you would, of the intervention program, what you were trying to do here, and maybe some insights into what you're finding.
I would be happy to. This is a program that has been funded by the National Institute of Nursing Research and the Office of Cancer Survivorship at the National Cancer Institute. Because we have so many women today who are cancer survivors, there are 2.1 million women in the United States who are breast cancer survivors. There are many needs that have been identified among the survivors after treatment has ended. We have had a wonderful, wonderful survival in terms of our treatments, so that women are living much, much longer, and in living longer have developed and identified very specific concerns after treatment has ended. Our particular study really targets women after the end of therapy, after they've had radiation therapy, surgery, chemotherapy. They may be on hormone treatments after their main therapy has ended. But what it is a focus on living well and living strong after cancer. And so with these women, issues around concerns of having fatigue, pain, issues in living with breast cancer, talking about breast cancer with their friends, identifying what has happened to them, moving on with their lives, going back to work, and concerns in relationships. Those are the issues that they have identified. So with our program, this Breast Cancer Education Intervention Program, we have identified very specific side effects that have occurred after treatment from our previous studies, and we focus on those specific side effects in terms of support and education for women. We've had 260 women that have participated in this study, and they have primarily come from the Central Florida area. They participate for 6 months. We have a one-on-one nurse intervention program for the women where the nurses will sit and discuss these issues with them. 3 specific interventions where they will talk with them, go over very specific information. We have teaching materials, modules. They do homework. We have we establish a good rapport with them. Then on a monthly basis, we provide telephone contact with them. Any information, concerns that they have, they would like to raise in discussion for a period of time, they can do so and be able to get through sometimes what is a very difficult time. After they get through that time period, generally after 6 months to a year, people tend to move on, integrate the breast cancer experience into their lives, and move on with other aspects of their lives so that they can become thrivers after cancer has occurred.
Thrivers and survivors as well.
Thrivers and survivors.
You know, one thing that really stands out when you talk about someone who's diagnosed with cancer is it's not like other diseases in the sense that you take some medication and hopefully you are cured. There are a number of other factors that begin to play into it. You've got the family factor, how the family will relate to the person with cancer. You have the ongoing, as you'd mentioned, care type of programs to make sure that the cancer either doesn't come back, or if it does, how to best treat it. Like I say, it's a lifestyle change. You get cancer once, and it's not like it just goes away. You continually have it as a part of your life.
And that is the other side of cancer today. When it was initially looked at cancer, even 30 years ago, pretty much as a terminal disease. And today we don't look at it in that way. These are people that can live for a long period of time, and it's a chronicity of the cancer that makes it all the more important to talk about how does one live with their lives after having had cancer. The part about family is so important as well. Many of the women that are diagnosed are usually in their 40s, 50s, 60s. Oftentimes they are very, very, very vibrant. They're working, they have families, they have children, they have spouses, they have partners, they have grandchildren, all of whom have been also affected by the disease. And so how they get their experiences out in ways that can be discussed and communicated and making a difference in other people's lives becomes very important. Women have just been so phenomenal in terms of their survivorship and the ways in which they reach out to other women and other families to share their experiences has been incredibly powerful. It's that whole advocacy related to cancer.
Are you finding through the research that while we are doing much better and making great strides in treating breast cancer, at the same time we are opening up new areas where we don't have as much experience or knowledge? Talking a little bit about spreading the word, talking about getting some of the additional mental counseling, those types of things that perhaps we're not as advanced as even the medicine is in trying to treat that part of the cancer patient.
That is really the catch-22. We now have, through the Institute of Medicine, they've issued a psychosocial report on women with breast cancer and some of the needs that we have seen through our practice and through research over many, many years. It's just very difficult getting some of those specific concerns out into the public because sometimes people just don't want to talk about them. And it's the women themselves who share their experiences, and they can see, other people can see, wow, this person has dealt with this particular issue in this way, and here's what the research says about that, and here's what we're learning better in practice to be able to improve on that. And I'll give you a couple of examples. One is very simple, that after treatment is ended, either for surgery or after radiation therapy for breast cancer, the type of surgeries that we used to do in the past increase the odds of women developing lymphedema, which is an increase in lymph that occurs and trapped actually in the arm, and it can be very, very painful. It can be very difficult to manage. Women have a difficult time in terms of just moving their arms, and so we've learned that that is a problem that occurs after treatment. So what can we do about it? Well, one is we can first of all teach women more about that this is a common occurrence that can happen,
and eliminate some of the frightened nature of it,
and the concerns, and help to bring that
Sure.
concern down. Talk about how exercise is also very important. Talking about just ways that they can manage their arms and just hands, just simply even just good arm and skin care so that that can help to reduce the likelihood of that side effect happening. We're also learning today with the additional research that it's really, really important for women, particularly breast cancer survivors, to continue to exercise or to start not a rigorous exercise program, but simply even just exercise, walking for 30 minutes a day or 2 15-minute time periods a day, just to walk 3 or 4 times a week, because there's new data that has come out that shows that women actually have reduced experience with recurrence after treatment is ended. So there you have this modifiable way of managing a potential devastating recurrence of disease.
You touched on a very important point, I think, for a lot of people, is that because of the knowledge that this is a potential threat to women as well as to men, people are taking better care of themselves. And even with that, you find people, because of the genetic portion of this, the genetic component, if you will, that they can take great care of themselves. They don't smoke, they don't overindulge in many things. They may exercise, and yet they still get cancer. And that, from a psychological standpoint, I would think would be very difficult to deal with too. I did all the right things and I still got cancer.
Very much so. Today we know about 5 to 10% of all breast cancers are related to genetics. So there is an inherited predisposition. They inherit that genetic defect from either the father or the mother. And so you look at them, they say, wow, I've done all of the right things. I've exercised, I've maintained my weight, I really do well with my lifestyle, and yet I did develop cancer. And that's very, very difficult at times for them to be able to manage. And yet on the other side, when you know you can modify your risk when you can reduce your risk somehow with exercise, with good eating, with not smoking, and managing your life in that way. It helps to reduce other risks from other cancers, and so that actually is a positive thing.
Sure. Well, especially important for, we talk about the genetic component. You know, mom had breast cancer. That means the daughter's risks are higher, so they at least have this window, this knowledge that maybe I need to take extra care of myself because it is obviously in the genes somewhere.
And all the more reason for women who have a history of breast cancer in their family to go for their mammograms and to go see their primary care physician, their nurse practitioners, to be able to talk about these issues with them and say, hey, what are my additional risks, and how can I actually manage my life in a way that I'll better understand what this disease is and what I can do to reduce my risks.
Studies like the BCEI that you're involved in seem like it would help not only the people in the United States but around the world as well. And yet it would seem there's a lot of barriers. You know, research will take place in a particular country, and because we do so much research in this country, we seem to benefit from it. But yet there are those times, because of language or sometimes just agreements and difficulties in crossing the borders, that it doesn't get out as much. Are you a component of that? Are you trying to try and get some of the word out to other parts of the world, get this translated and that sort of thing?
Absolutely, absolutely. I'm involved in a number of other projects. Another project that we're working on and currently funded for that relates to women, younger women who have fertility concerns and pregnancy concerns after treatment. Many of them have had chemotherapy, which can have an effect on their fertility, and yet if they're diagnosed at a younger age, 30s, mid-30s, they may not have either finished or started their childbearing or having had children. And so we talk about that with them. But there are many women around the world that don't generally get that kind of information. And so another project that I'm involved in is the use of the internet as a vehicle for helping other women around the world to receive this information. And we have women who have participated. At first, our target was in the United States, and then when we realized in conducting this research through the internet how women can find out information about fertility and breast cancer, and have actually been participating in our study. Half the women in our study currently, we have about 50 women in the study, they're from the United States, but the other half do come from other countries, Australia, UK, and also from Canada, and they have actually been able to work with us on this project. We've been in contact, or actually been contacted by a number of other researchers, specifically in Australia, who have looked at our information at our website and wanted to use the information and develop information actually on the very same topic for women in their country. And when they came across our research study, asked if they could look at the site and give us credit, obviously, but to look at the site and to be able to use some of the information that we had.
You've done a lot of work for them, basically, made some steps.
And it worked well in many ways, because if you look at the internet and you say, well, there are people who may not be able to access it, what are the other traditional ways and means? It's simply from developing pamphlets and written materials so that they can distribute those materials for their patients. So that has been a wonderful outgrowth.
Is this a two-way street? You're gathering information. You are, trying to work with breast cancer survivors who have benefited from medical knowledge and medical research, and you're sending information out. When you get the information back in, does this translate into something that will help the medical side, the treatment side as well?
I would hope so. I would think that from the information that returns, we learn much more about specific topics, about symptoms, about how to manage symptoms better, how to prevent those symptoms, how to deal with women. And for example, the topic about fertility, oftentimes medical personnel aren't really as comfortable talking about what happens in women's lives or what happens in patients and families' lives. We're sometimes so focused on treating the disease, on providing really good state-of-the-art cancer therapy, and that's very, very important. But the other side is the human side that you talked about as well, the human aspects of living with this particular disease. And so how do we then help medical personnel, physicians, nurses, social workers better bring up and communicate in these issues? Communication, cancer communication is a very, very important field and very important topic where we sometimes don't do very well with. And we know we have the knowledge, but sometimes we don't communicate it well so that patients and families can really hear it.
I've actually heard that before where someone will say, my doctor knows an awful lot, but he's got a lousy bedside manner. and that was meaning, he doesn't understand what I'm going through. Yes. He may be able to treat my symptoms and give me the medications and the treatment that I need, but he doesn't realize that I'm having problems, dealing with this, or self-image in some case. And it's difficult. It becomes a two-way street, blocked, because the patient can't really tell the doctor, who they feel doesn't really have the capability to understand. They don't have that knowledge.
And many of them try, and I think that that's part of the outcomes of research, and in terms of the communication and how do we better communicate with one another so that I, as a patient, can share my information, and my family can talk about that, and how then it can get translated in hearing it, in better hearing it.
Does this relate to the big world, if you will, of all kinds of cancers? I mean, we've been kind of talking about breast cancer in particular, but obviously there are many different forms of cancer with many similar circumstances, symptoms. Sometimes treatment will be similar, but it may affect different parts of the body, but a lot of the side effects are somewhat similar.
Oh, absolutely, absolutely. We have currently another researcher in School of Nursing whose area of research is in prostate cancer. And we have a great deal of information that we know about treatments with prostate cancer. But one of the other side effects of treatment is that patients can become incontinent, and how difficult that is, and how do they manage that better, or how do we develop new treatments that are going to reduce the potential for that to happen. Patients who have lung cancer, dyspnea or shortness of breath is a great problem. It's a great deal of difficulty, and it's very, very scary for family members as well. How do we deal with that? So how can we communicate that specific symptom in a better way so that the oncologist and the oncology team can hear it, and that we then can be able to translate that better so that we can reduce that perhaps in the next patient that comes. Colorectal cancer and colorectal cancer screening is also very important, and it's an area that most people don't really want to talk about, and yet those 4 cancers represent 50% of all adult cancers. So I believe, yes, if we have information in one area, for example about breast cancer or prostate cancer or lung cancer, can we use that information to translate that into another disease and use what we have learned, for example, communication.
Are you getting input also from the families, from those closest to the patients?
We do. We do. Family members have a great deal of say and concern about their family members who've had cancer, and oftentimes they're the ones who are oftentimes forgotten. Many times in our treatments we focus so much on the patient. Patient families today, they can't always accompany their family member for treatment. They're working. They have a lot of concerns perhaps about what is it going to cost, and what are these out-of-pocket expenses that are going to be incurred as a result of their family members having treatment for cancer. And so they may not always be able to come and accompany their family member for their therapy. And oftentimes too, they have so many other concerns. What will my life be like? We have children. How are we going to manage that? How am I going to take on the burden of, in many ways, the roles and the responsibilities of their loved one who's going through cancer at that time? How do the children respond? What do they want to know? What are their concerns? What are their biggest fears? And usually it's of their family member. They think their family member is going to die. So how do we share good information with them, realistic information, but also maintain a great deal of hope and cohesion in that family?
That must be a tough line, because I know what cancer patients want to hear most is you're going to be cured. But there's also a realistic factor of what the statistics are, and it's a balance of being able to not give them too much optimism or making them overly optimistic, but also to encourage them to fight this.
Yes, there is, because in many respects what patients and families want to hear is 100%. They want to hear 100% versus 0%. And oftentimes you can just share these are the risks and this is the survival. But in their instance, it has to become meaningful for them, and they need to know that. And so by communicating, really good communication between the patient, family, and the oncology team, if you have that, then you know that the communication is open, and so that there can be free flow of questions. Unfortunately, even in our own healthcare system today, that doesn't always happen, and it is not because oncology teams don't want to do that. It's just the nature of our system in terms of insurance and reimbursement. They can't always just pick up the phone and call, and so that was part of the secondary reason for the development of our BCEI. It's a time when people have the largest concerns in terms of their cancer, but it is also a time of diminishing contact with their healthcare team. And so by our bridging this point after treatment ends to the 6-month follow-up, it's a way of helping to improve that kind of living with cancer and helping them to thrive in a better way.
One thing I know that you've done, which wasn't directly related to the study certainly, but is something that I found rather interesting in our pre-conversation, was bringing in this case I believe it was ovarian cancer patients, to a classroom setting.
Yes.
And that last fall you mentioned that they had an opportunity to actually share some of their experiences. And I found that really fascinating, because so often there are people who want to know, but it's a touchy subject. I mean, you don't necessarily know whether you can talk to someone who has cancer and ask, how are you feeling? I mean, really. You want to hear from the patient. You want to find out what's going on, because that's part of your education process, and hopefully you'll be able to better relate to someone who has cancer, whether it's in your family or otherwise. But I'll let you pick it up from there and tell me a little bit about this forum.
It was really quite interesting. I work with cancer advocacy groups, and specifically with breast cancer advocacy. However, I'm also very much a part of ovarian cancer advocacy here in the Central Florida area. And we wanted to develop a venue in which there would be a better way for survivors to communicate and to share their experiences. And also being on faculty in the School of Nursing, oftentimes we want to really use real-life experiences, and in the classroom setting it can be a number of different ways, but one of which has been through case study. We present the information, we share the information with students, and then we present a case study. And in this instance I thought this would be a great way for the students to hear firsthand, and so I invited ovarian cancer advocates and survivors to come into the classroom and to share their experiences. And as it turned out, there were 3 of them that came, and they each shared a different experience with ovarian cancer and had a wonderful exchange with our undergraduate students in that class. And it was so meaningful for the students, who after class said that it just so came alive for them, that they had either no idea, they had a little experience, or now they had a better means of communicating based on the experience that they had with the survivors in the classroom.
That fascinated me, because here are students and professionals who, they've read the books, they know how it works, they know what the reactions are, they know what's going to happen, and if they were able to learn things and understand things better because someone who actually had the cancer was able to tell them how they felt.
It's directly from the patient herself, and it made such a difference. It was a very powerful experience. And
what kind of questions were they asking? Can you recall offhand?
Some of the students?
What were the students asking?
They wanted to know what it was like to live with cancer. They wanted, and that isn't in the book.
Yeah, it's not part of the textbook.
They wanted to know other kinds of side effects that occur after treatment ended, particularly with ovarian cancer. Go beyond the nausea, you go beyond the vomiting, you go beyond the hair loss that you see in the acute care setting. What was it like? What is it like to live with a disease that many times has a very grave outcome?
Do you think about dying? I know that's a question I've heard asked of patients before.
And how do you deal with that? Because being diagnosed today with ovarian cancer, if it's in the early stage, is very good survival. It's oftentimes, though, that they're diagnosed in the later stages, because ovarian cancer is considered a silent disease, unfortunately. And so women do live with a shorter overall survival. And so what would that be like? And their candid sharing of their experiences, and what would that be like for them to walk through the dying experience, was very powerful. It's very powerful. We all are going to die. We don't want to think about it very often. And I believe sometimes death is really treated as a failure in this country, when in fact it's a part of our living and dying.
Well, you sit there and you think, okay, here are the students who are asking these questions, and fortunately they have a source for them. So I think I called it bedside manner earlier. They're going to ingrain that in their studies and take that message out, and hopefully make the whole process a little bit easier for the patients that will come in the future who are diagnosed, because they will have, oh, I remember hearing from this ovarian cancer patient that this was their reaction to a situation. Here's another ovarian cancer patient. Maybe what I have learned will help them.
You would hope that that really was a very teachable moment, and that that stays in their mind as they bring those experiences into the clinical setting as well. Cancer is the second leading cause of death in this country, and it is very unlikely for any nurse, healthcare professional to not deal or see or take care of a patient with cancer. And in addition to that, their friends, their family members, their neighbors, who all may have had a diagnosis or may be facing a diagnosis of cancer.
With 1 out of every 7 women with breast cancer, it's hard not to find someone who doesn't have a family member these days that's affected by some form of cancer. I think it's 1 in 4, as I recall, for all forms of cancer. You're in the midst of crunching the numbers, I know, in your study now, so that's going to take up your time for a few more months. But what do you see next? I mean, what types of what's still untapped? What else do we need to do to get the message out and get the information in, so to speak, when it comes to breast cancer and other forms of cancer as well?
I think it's so important for us to reach out to our, quote, underserved populations, and our underserved populations may be minorities who may not have access. They may be the very poor in our cities and in our country and in our states, and also to the rural populations. And in fact, our next series of studies really focusing on translating the data, the results that we have in our current education and support program for women who live in the rural areas here in the state of Florida. And so that's kind of our re-looking at our research and saying, how can we better use this information? Most often, survivors in rural areas don't have access to the information. They travel a great distance in order to receive their care, and after their treatment has ended, they go back into their communities that may or may not have the information for them. And so we've developed a very low-tech alternative through the telephone way of intervening and sharing this particular intervention with them. So that is our next series of studies that we're looking at.
Sounds like a real grassroots effort. I mean, if you're getting back to the phone and the primitive forms of communication, at least they're primitive by today's means, it seems.
Yes, very much so. I also believe here in Florida, in the Central Florida area, it's so important to translate our materials and to use them in other languages, and specifically with Spanish. We have most of all our materials are in English, and so how do we then be able to reach out to other populations that may not necessarily use English as their primary language? That's very important.
All knowledge for all people.
Absolutely. So
Karen,
that would be our second.
Karen Dow, thank you so much for coming by and sharing the information with us. We'll have you back sometime, and once you get the numbers crunched, we'll find out a little bit more about your study concerning breast cancer.
Well, thank you.
Thanks for joining us as well on Profiles. We'll see you next time. I'm Ed Highland.